Hey, get in, fellas. We're going back to therapy, everybody. Welcome to season 2, where the session numbers are going away. We're just going to be having you go block by block. So if you want to take on these interviews in a new and different way, not necessarily in order, but in order of each block to learn, we're going to be starting addiction block this week. So this is the introduction episode to addiction block, or the theme or stage of change, which we'll learn more about, is pre-contemplation. A person who may need to change a behavior is not yet ready to do it. That is the idea here. We're going to go from learning about pre-contemplation to learning about harm reduction, which is the way that we can help keep people safe in a situation where they're not ready to yet change the behavior they're doing, specifically around drugs, substance, alcohol, all those things. We're going to have on a good buddy of mine, Dr. Drew White, out here in Denver. He works in the addiction world and did extra special training in addiction, so we're lucky to have him on to understand some of the science, most of the biology and the psychology behind addiction as we get started this month to understand what treatment looks like. And finally, we're going to have our BHoF introduction, a guy who's really well known in at least the Barstool Bro community, Paul Bis-Nasty. He got into a little bit of trouble this week while looking to defend somebody else. And he also begged the question is there a role for physical violence when we're trying to be kinder, gentler bros? And the answer is maybe. Stick around for the end of the episode to see that. And otherwise, let's go.
What up, everybody? Welcome to the introduction to the addiction block, or what is our second episode since starting season 2. If you didn't listen last week, we took a really interesting angle on the mental health theme, noting that because it was Thanksgiving and Native American Mental Health Month, we went all into understanding the situations and current mental health state of the Native American community here in America. So if you missed that last week, really welcome you to take a listen to that interview, and I really enjoyed it. It felt like I learned a lot. This week, we're going to start on something that I think impacts us a lot more, which is the idea of addiction. Okay, so generally speaking, from here on out, we're going to be doing blocks of episodes. Those will be anywhere from 4 to 6 episodes long. And that's really going to help you take the stuff you've learned in the first season of this show, which is understanding therapy concepts, understanding people, understanding behavior, and taking those things out into the real world. All right, so with introduction to addiction with me and Drew here in a little bit, I wanted to have you think about addiction as a construct. We talked about CBT and those negative thoughts. We might use behavior, we might use substances to get rid of those negative thoughts, to help us tolerate distress, like we learned in DBT block, to help us deal with trauma and issues with our relationships, like we learned in psychodynamic block. So just to think about this more broadly, you've already learned the concepts on this show to help understand somebody who's had addiction. If you've been a big fan of this show, you've heard me talk about how, as a framework, addiction implies that we're going to do something, a behavior. We think substance use, sex, drugs, rock and roll, zoning out into our phones, sports, gambling, any of it, to take away a feeling we wish we didn't have or give ourselves a feeling we wish we did have. Sorry, not sorry. You're going to hear that a lot during this block on the socials, everywhere, because I think if we could understand that core concept, we would all have much more empathy around addiction and, again, not consider it a moral failure. Today, we're starting with pre-contemplation. The idea of the stages of change, Drew and I will get into more. We are starting with the first stage. As you look to change a behavior, you undergo certain thinking, kind of like we talked about the stages of grief, but pre-contemplation, I'm not ready to change. Contemplation, thinking about it. Preparation, here's what I do to need to change. Action is that change, undergoing that change. Maintenance, how can I keep that change ongoing when I've changed my behavior? And then we're also going to do an episode on relapse, because with most behavior change, and specifically, unfortunately, with substance, relapse is often a part of the process and often a part of the package, and something we'd like to normalize on this show so that it's not carried around with as much shame as it does. But most people going through addiction and treatment of addiction end up in relapse at some point in time. So today we're in pre-contemplation. Holy, what that means is I don't see a problem here. People come to you telling you, hey, your substance use is getting out of control, or your doctor tells you that your cigarette smoking is going to take years off your life, or, you're running up credit cards because of a shopping addiction, or you've lost all your money because of a gambling addiction. So people will think that because I don't misuse substances, Dr. Solomon, well, I must not have a problem. I must not have a use disorder. Well, if you look in the big purple book, right, there's going to be use disorders for everything. Sex, drugs, internet, video games, gambling, shopping, eating disorders, taken to a certain limit can be considered a use disorder if it impacts your social and occupational functioning. So that's you having a job, it's you being present in your relationships, it's you being a good parent, being a good friend, being a good role model. Any of those things that are a part of what our life should include is going to be a part of how we judge if these things are a problem. And so today we're going to be focusing on pre-contemplation with me and Drew. So getting a lot of the background to understanding addiction is why we're calling it that, an intro to addiction block. So pre-contemplation is a place we all can understand, we've all been, which is somebody comes to you with something that they think you need to change and you go, what the fuck's the problem? Often a lot of denial, some projection, really not at our best self when we're in pre-contemplation. One of the main celebrities out there who's struggled on and off with addiction is John Mulaney. You know, he's a guy who's had some ups and downs with it. He's been honest about it. He's had long periods of sobriety. He's made references to it in his comedy. And I wanted to share an interview with Theo Vaughn, a popular comedian in that Austin group with Shane Gillis, where he has John Mulaney on, and John talks about some of the thoughts that somebody who's in pre-contemplation might have.
You were deep in, huh? How'd you get so deep in? Because I don't think anyone would look at you and think this is the Coke guy.
Good. That was the whole thing. I mean, I certainly tried to talk about it on stage as having had like a drug and alcohol problem, but it just, I don't know. It didn't, something about me seems, so to me, it's like, well, of course the guy that seems like he has it all together has the problem, because that's just like how life is.
That's Texas. Yeah, it's almost like
it's textbook.
Yeah.
But that's I don't put that on you to be like, how come you didn't see it? Because I really thought that I was doing life. I was able to achieve it life with the drugs as opposed to in spite of them. It took me a long time over the past couple of years to realize that I did well at what I do in spite of drugs, not because of them.
Wow.
Yeah.
Yeah, because it'd be fun. Yeah, from an outsider, I would always look at him and be like, oh, that guy, yeah, drugs would not help that guy. Like, that guy is his own. He is so unique in his own way that anything to abase that or something or debase that would only mess him up.
But I would have thought like, I'm delivering something people really like, and I think I'm delivering it because I take 2 30-milligram Adderalls and then 1 Z-bar, and so I'm really sharp, but I don't seem jittery, and so I go on a podcast or I go on a talk show, and I'm delivering, and I'm giving people what I'm naturally good at, but I'm a little tired, so I can't naturally do it. So it's okay. It's okay to rip open time-release Adderall and dump the beads down my throat and then pop a Klonopin, because then I will get to the level that I naturally am at. Like,
so if you didn't get John's references there, 60 milligrams of Adderall and 2 milligrams of Xanax at a time, that's a lot of medicine. We don't do that. Opening up the beaded capsule and dumping them into your mouth with a Klonopin, we also don't do that. Those are not safe things to be doing. We follow our doctor's orders. But the reason I wanted to use that clip with John is, one, he's been very honest about his substance use issues over time. And so it seemed like a fair person to use as an example, because he's had honesty about his addiction, and he's also had honesty about his relapses too, including a most recent relapse and another trip to rehab in the year 2024. Some things in that interview with Theo that I think are worth reflecting on is we want to normalize this idea of addiction and really welcome people to listening to these episodes and thinking how it impacts them and how it impacts their loved ones. So John talked about, heck, even Theo said, you weren't a guy that I thought would have a problem. And John's like, well, that's interesting, because I talked about how I had a problem, right? And so the idea that maybe how we view somebody as functioning, or how we see how they're doing, or what their job is, or how much money they have, does not indicate whether they have a problem with addiction. In fact, addiction as a whole, as a construct, really knows no bounds. Thinking about fellas here on the Get In Fellas podcast, we know that men have addictions to work, where that is what they use to feel good. They cover up their emotion by working super hard, coming home late, diving into their computer. It's what they can control. It's what they do. Having money predisposes you to be able to afford things that can lead to addiction. And again, we think of drugs, of course, and substances really are common across the map in terms of race, religion, culture, social, economic status. So first, we don't know who's struggling. I think what John noticed was that kind of talk that people might get into when they're in that pre-contemplation stage, which is like, well, if you didn't notice I was having a problem, or you don't notice what I'm doing, or it took you this long to figure it out, you might be confronted with that by somebody. And so just to know that this person, again, feels bad, they feel guilt, we need to roll with the assumption that anybody who's struggling with an addiction wishes they could do better, and they just don't know how. And so, John being like, well, if you didn't notice, then it must not have been that bad. Just know what's going through the mind of somebody like John in that situation, which is, I know I'm doing wrong and I don't know what to do, so I need to offload these negative feelings onto you. John hit our construct right on the head, which was, well, I'm naturally good at being funny. I just need these medicines to make me excited and energetic, but also chill. So he's taking super loads of both an upper and a downer in order to strike this balance, but he feels like he has that balance. It's just a larger version of who he is. It just makes him a little better at what he already does naturally. That's the kind of talk that should certainly concern you. But specifically, he was trying to give himself this feeling, right, of being a perfect on-stage comedian, of being locked in such a certain way. So when we think about this construct, take away a feeling, for him, maybe the Xanax takes away a feeling of insecurity or takes away those anxious thoughts. Well, the stimulant Adderall gives him that feeling of being lively, fun, energetic. So we're generally using substances, we're using behaviors to give ourselves that feeling or take away. Okay. So I want to transition into a topic that's super important when people are struggling with substances, especially early on, and that's harm reduction. All right. Well, there wasn't really a better place to put this in this block. And since it seems like a pre-contemplation type theme, I want to focus on this. Harm reduction is how it sounds. Okay. The idea that we have to accept a situation as it is and prevent as much harm as we can in that situation. So I really focused on this principle as a whole during the DBT block when we said, let's learn how to slow our minds down so the behaviors that follow this don't make things worse. We don't blow up relationships. We don't use substances. We don't self-harm. And we don't end up in positions or behaviors that can end up forming an addiction, can end up forming a process in our head that says, if this happens, then I immediately have to do this to make myself feel better again. So harm reduction, more specifically in the substance use world, is the idea that we use practical strategies and ideas that are aimed at reducing negative consequences associated with drug use. So in general, this has become much more than that. It's a social justice movement that is meant to ask realistic questions around substance use and provide services and resources for people who are struggling. Maybe they're not ready to give up substances yet, like we're talking about in this pre-contemplation stage. So how can we make things safer for people out there? So I want to share a list of principles. I'm using harmreduction.org's mailer here, and to just focus on what are these principles of harm reduction. So it talks about that as harm reduction, we accept, for better or worse, that illicit and licit drugs are a part of our world. So we accept reality, right, guys? People are doing this. This is out there, and we as a society need to figure out what can we be doing to help address these problems realistically. We've learned abstinence is not an answer. Abstinence is not going to be something that we can expect from society at large, while we hope individual people can strive for abstinence. We understand that drug use and addiction in general is a complex, multifaceted phenomenon. There's all types of different behaviors that get wrapped up into substance use and get wrapped up specifically into addiction in general. And that we understand that, for people to live a good life, they might not need to be abstinent, but that they need to be in better control and functioning better over whatever their problem behaviors, certainly drug use, are. That we want to be non-judgmental and non-coercive, as we've learned in our mindfulness blocks, and work really hard, as we did in this first season, to understand the lives of people who are struggling in this way. The more empathy we build, the more that we can be less angry and able to help and at our best emotional selves. So we want to make sure people that are struggling with drug addiction, this is again a nationwide policy, have a voice in terms of how these drug, harm reduction strategies are used. This organization uses the term people who use drugs, or PWUD, PWUD, that we understand, just like with DBT, that people who are struggling with an addiction are, in general, they are the primary agents of reducing harm of their drug use or their problem behavior. And we want to share information that allows them to rise up, recognizing, just like we talked about earlier, that these types of behaviors do not know bounds by race, gender, class, money, job, anything, that this stuff impacts people all up and down the social ladder, and that we do not try to minimize or ignore the real problems that are associated with drugs or other behaviors. So we are not saying, when we talk about harm reduction, we're not saying it's okay to be using substances like this. We're saying that, hey, this is the reality we have to accept, and that we need to be focusing on realistic strategies to help an everybody problem. That's a big theme of what we have here on the show, which is, hey, if there's a problem in this country, we need to come up with solutions that everybody is a part of. Okay, some ideas of things that have been great harm reduction strategies in terms of public health over time, right? So the invention of birth control, public communication and public education about sex, using birth control, using condoms, using abstinence in situations that call for it, but kind of sex education is considered a harm reduction intervention. Needle exchange programs, clinics that do free HIV testing, other examples in the substance world in particular, methadone and Suboxone clinics, right? So those are things that allow you to stay on a medication over time to help make sure that you don't relapse into heroin use. The availability of Narcan. You can buy that stuff at the grocery now, right? Because if you have someone in your life who's misusing opiates, or you just want to be a good citizen, a Samaritan on the street, if you see somebody who has probably overused opiates and are having a hard time making words or breathing heavily or breathing shallow, if you run across a person on the street who isn't conscious and is breathing very low and very minimal, chances are they're in the midst of an opiate overdose, and you can use Narcan, this nasal spray, to help reverse that overdose. So all those things are an example of harm reduction strategies that are realistically saying this is a problem. And in the meantime, we can have ways that save people's lives, also save money, save resources for the economy, and are nice balanced approaches. Harm reduction as an entity is something we can think about, not just with substance use, but other things in our life. Gambling might be to reduce the units we're betting on or the amount of games that we're willing to bet per week. If you're a cigarette smoker, hey, harm reduction means I'm going to cut the amount I use blank. That's also a preparation stage when we're talking about stages of change. Pre-contemplation, harm reduction, they go hand in hand. Okay, we're going to be realistic on this podcast about the challenges as we enter into this interview with Dr. White. Again, we're very thankful to have him. I want to say, hey, addiction is normal. It is an unfortunately common part of the human experience. And I hope that over these next few weeks, we all get a good understanding and feel like we're ready to support ourselves and others who struggle with this. All right, we'll be back with Dr. White. See y'all in a second.
Ladies and gentlemen, thanks again for joining us. We're super excited to be kicking off season 2 with the good Dr. Drew White. This is going to be our introduction episode to the addiction block. We're going to be focusing a lot more on substance use, so alcohol, nicotine, other drugs throughout this, because that's kind of the common thinking when we think about addiction in this country. So we're going to stick with substance use as our primary marker and the primary thing we're learning about over these next 6 blocks. Drew and I will take the time to kind of explain what these episodes are going to be and how much and how you're going to be learning these things. Let's introduce our dear friend, Dr. White. Thanks for joining us. Dr. Andrew White is a native of Aurora, Colorado. That's over on the east side of Denver. He studied at the University of Denver and did med school at a little school you might have heard of called Johns Hopkins. Did his psych residency and addiction psychiatry fellowship out of the University of Colorado, which is where I met him. So Drew, after completing his addiction fellowship, is now serving as the medical director of adult mental health services at a public safety net hospital here in Denver. After finishing his training, Drew is now serving as the medical director of adult mental health at Denver Health Hospital here. I did a lot of training there and have worked all over that place. And, it's the public safety net. They do a really good job dealing with a lot of diverse populations and a lot of Medicaid type populations. So they do a really nice job for that, considering their limited resources. So Dr. White's favorite mindful hobbies are yoga and cycling. Dr. White, thanks for joining us. What do we got to say to the people?
Pleasure to be here, Dr. Solomon.
Yeah.
It's like it's a bro dream of mine to sit down with you sort of formally and informally and maybe, at the end of our time, shed some light on a topic that has lived in the shadows, I think, for a vast amount of our time in humanity.
Yeah, totally, Drew. I think, as Dr. White and I just kind of thought about this block, it's what this show's trying to do, which is destigmatize and normalize these kinds of conversations. So we're going to be talking a lot about treatment. Today is going to focus more as an introduction. So that's why we brought Drew on, because starting this season, we're going to get into topics that I am not an expert in any longer. And so I want to be bringing on clinicians who are experts in their field so that we can keep learning. I can be learning. We can keep putting good information out there. So, Drew, addiction, what did you learn in fellowship? Why should we care about addiction? Let's start the people off with some commitment to the cause.
Ooh, yeah, it is. I think we got a lot to chew on today. For me, I think if we start kind of globally at the core of addiction as men in today's society, I think there are numerous personal aspects to it. I don't think anyone kind of gets into their early adulthood and later on in life without being exposed to what addiction can mean, whether that is personally losing control of certain behaviors that might lead to negative consequences, which is kind of a framework of looking at addiction, or being associated with individuals who are struggling with their own behaviors and kind of being the bystanders to
the loved one, the family. Yep.
Yeah, that we can't control. I mean, for me, one of the things that got me into studying addiction and psychiatry, generally speaking, was being brought up in a family that had numerous folks who struggled with addiction themselves. I think the global picture of addiction that I kind of pulled a stat to get us started talking about it today, WHO, or the World Health Organization, came out with a study in 2023 and showed about 5% of all deaths in the world, so every single person that we have records for, were rooted in alcohol use. And that includes accidents, overdoses, withdrawal issues. But I think when we look at 1 in 20 deaths being rooted to the use of a substance, I think that maybe kind of resonates with the experience of the typical average Joe who might be walking down the street. More, locally in the United States, I think anyone who's kind of been privy to some of the trends that have happened in our communities since COVID onwards, I think another startling fact that sort of inspired me to do the addiction fellowship in general was built on this opioid crisis that has evolved. So, kind of looking back in the 90s, early 2000s, and now we're getting into like our third iteration of the opioid crisis and kind of fourth iteration now as methamphetamine becomes an issue mixed in with opioids. We're losing about 80,000 people a year to overdose deaths. And, when you contextualize that to something like the Vietnam War that had about 60,000 American deaths, we are losing a war's worth of individuals every year, despite our best effort.
We know that men, more than women, are significantly more likely to have consequences, deaths, or just illness, mental health concerns around substance use. And why, as we'll talk about? Because they're avoiding talking about feelings. Generally speaking, that is why we use substances. We'll think more about that later, but it leans towards men because men struggle to get those feelings out and substances allow them to ignore whatever's going on.
Couldn't have said it better myself. I think if we kind of look at substances specifically or some of the compulsive behaviors that come with, as we look at it in psychiatry, these notions of like use disorders, so like a disorder of behavior kind of within the disease model, there is a draw towards eliminating negative feelings. In so much, as we kind of look at some of the realities of addiction in the US, and kind of ask ourselves, well, like how common can this be outside of just death and overdose death and some of the endpoints? The CDC's most recent studies from back at the end of 2017, back at the last decade, pointed towards about 20% of individuals at any 1 year chunk of time having a substance use disorder.
And more as we get into other episodes, guys, but a use disorder is the term that the Big Purple Book asks us to use to quantify. And so if somebody meets criteria for a use disorder, it's pretty serious, it's pretty consistent use. It does imply that it is impacting, as we've talked about, your social and occupational functioning. So Drew, when there is a use disorder, can you talk about some of the criteria that we're looking for when somebody is diagnosed with a substance use disorder?
Yeah, I think there's a few different ways to break it down, but the core aspects, as you mentioned, involve a use of a substance, right? So you can't have a use disorder without the use of a substance. And once that use becomes perpetual enough, individuals start to show tolerance, so they need more of a substance to get the same effect. So sort of the notion that, oh yeah, I used to drink 5 or 6 beers and maybe get intoxicated on a Saturday night, but now I need 7 or 8 or 9 or 10. That's sort of the notion of tolerance. And conversely, when folks start to develop tolerance, they notice that if they reduce their use, they start to have withdrawal phenomenon or kind of a dependence. And withdrawal from opioids could be a good archetype to look at that, and can include things like anxiety, insomnia, irritability. But in my world and working with folks who kind of span a whole spectrum of uses and substances, I've seen that happen with technology use.
Yep.
I work with adolescents who are kind of trying to reduce the amount of time that they're looking at a screen. Marijuana use, which is often kind of stereotypically had this notion that like, oh, you can't withdraw from weed. And I think the conversation can go on for almost anything that an individual can get addicted to, whether that's sugar, caffeine, nicotine.
Yeah, totally, Drew. And I like that. So if you're taking away just quick points, the idea of tolerance and characteristic withdrawal, and including your impairing your functioning. And those are the things we look for, that tolerance and withdrawal. So Drew, I just was thinking as you describe withdrawal, I want to, just think about something that people might not have thought about during the pandemic. Drew, you remember when alcohol liquor stores were considered, mandatory be opening when COVID was starting at the beginning? And I wonder if people didn't understand that, some of the backlash that I saw. And hopefully people came to understand that if you are a around the clock drinker, an alcohol use disorder, moderate or severe, the withdrawal from alcohol is deadly. You can die. Same with benzodiazepines like the Xanax and the Valium and the Ativan. So the withdrawal from those things is horrific and can be deadly. So that's why we had to leave those stores open, as weird as it sounded, because Drew, what do you think? I mean, it would have been hundreds of thousands of people who would have been extremely ill given the rates we know of substance use and the people who have a round the clock tolerance at this point. It's sad. Those people obviously need help and need to start coming off those substances, but it would have been unsafe and unethical.
Yeah, I think you hit on a few points. One maybe common theme that will take us through all of the discussions in this block, which is this notion of stigma, right? The projection of our own personal values and our own personal experience on some of these kind of bigger systems level decisions. I remember during COVID having discussions with one of our main mentors in addiction psychiatry, Dr. Jonathan Ritvo, who
Legend.
Yeah, he is so legend. He's in books. They write books about him.
We're trying to get Dr. Ridville on the show. We'll see. He's a real bro, guys. He's a real OG of the addiction game, like Drew said, so much and so that he's been fictionalized in a couple of fun, very popular books. So we'll see if we can get him on. It'd be very cool to get really like a legend in the game's perspective on this stuff.
Yeah, and I think one of the things that makes him a legend, right, is the advocacy for that perspective of someone who's suffering. Some of the ways that we'll talk about substance use disorders and addiction in the coming episodes. We'll use all sorts of language, but I think at the end of the day, we can't lose sight of the fact that these are individuals suffering from a demonstrable pathophysiological change to the way that their brain is working, right? That the same machinery that we all love and embrace to kind of get through the day is fighting mechanisms that, to jump the gun on some of the things we'll talk about in terms of biology, but if we look at it, are really just a hijacked form of our most intimate pleasure-seeking capabilities.
Yeah, Drew, I think what's so interesting when we think about like the stigma of addiction and substance use is how it's been portrayed in pop culture, right? So what have you seen? Let's just think about that, because I've noticed that it's definitely changing with this generation, how people talk about substances and specifically treatment.
Yeah, I mean, we could go back to decades ago. There was reefer madness and these notions that, you smoke a joint and you become psychotic and manifest the devil. I think for a good portion of Western culture, there's been this abstinence drive. Has been so stark for us growing up, where I remember Jerry Springer and Maury and some of these shows where it was parents dragging their kids out of bed in the middle of the night to send them to boot camp.
Yep. That still happens. Those kinds of sending your kid to rehab, cover their head and chuck them in a van. It's terrifying. It still happens, man. I've talked to a lot of kids who that's happened to.
Yeah. And I don't, I'm perplexed at the phenomena of it, mainly because it doesn't work, right? As I'm sure when you talk to those kids, and I kind of see some of the adults, they're still coming in
And
It's got tons of issues related to it.
yeah, I've seen pros and cons of having to do it that way. I think, I worked in the eating disorder world where those teenagers didn't, it was involuntary for the most part. Most of those kids would not have come, to treatment if they had been given the choice. And so addiction is a tough one, Drew. If somebody is addicted to substances, getting them into treatment, we're going to talk about that in upcoming episodes, is a challenge. I think Drew talked about the negative part. I think abstinence as the focus in America is really a religious phenomenon. We're a primarily Christian-based country, and they focus on things like abstinence in a black or white thinking matter, as most religions do. And we've pushed more towards harm reduction. So like, if you're going to use safely is an idea of harm reduction. But I'm thinking back in the 60s and 70s where portraying psychedelics, portraying alcohol, a lot of that was very positive. I don't remember many, media from the 60s, 70s, even into the 80s and somewhat of the 90s that portrayed substance use as a problem. Most of that stuff has come more recently.
Yeah. Maybe it's part of the public education, right? If we show someone in their depths of despair, that will inspire change. It will teach my kid who's watching TV that they probably shouldn't be watching in the first place to not, use drugs or overdose. But it's hard. If we look at some of the shows that are out there now, like, you and I are racking our brains on all the different TV shows that come out with addiction as a theme right now. I mean, Euphoria is one of the ones that HBO put out. I think does a pretty eye-opening job of showing the nature of substance use in adolescence, in teens, right? That it's not just a couple of kids smoking a joint behind the bleachers, that kids who are getting hooked on fentanyl. I think Rue might have been the main character's name. She was struggling with her dad getting diagnosed with cancer and kind of got hooked on some of his pain pills.
Yeah. With the teens, like 13 Reasons Why has done this. Stranger Things touches on addiction. So like huge shows. And in terms of the problems it causes, the shows in adult world, like I think of BoJack Horseman, which we'll talk about a lot on the show because of its deep psychological themes. House, he has a big substance problem and goes to treatment during the course of the show. And so just thinking that we show treatment as a part of the process is a newer thing, which is excellent. And definitely a part of why we're doing this is to kind of normalize treatment and people seeking it out. Maybe we're getting away from like One Flew Over the Cuckoo's Nest kind of thing, Drew, which probably did a lot of negative things to encourage treatment and portraying mental health in that way.
Yeah, and to take that a step further too, also kind of open our minds to the reality that it is far from over, right? That seeking treatment as a cultural norm is a lot different than embracing treatment or instilling harm reduction. One of the most recent shows that it's one of those shows that was like almost too close to home to watch for entertainment value as an addiction psychiatrist is called Dope Sick. It's like it was on Hulu. It had like Michael Keaton as a physician who was treating folks in like, I think it was like the Appalachian region struggling with opioids. And then he goes through catastrophic injury and kind of gets hooked on opioids himself and starts going through treatment, starts methadone maintenance, and is never able to return to practicing medicine, right?
Yeah.
And I think we could talk for like hours about the like pros and cons and ethics of that. Would you want your physician on methadone? But would you want your physician to have an addiction? And that's an interesting question. Would you want your physician in treatment versus not in treatment for that addiction?
Yeah. It's true. I mean, guys, doctors are not, without flaw. A lot of doctors have issues, trauma, mental health disorders and substance use disorders, very common. It's a high stress job. I think everybody knows that with doctors and other mental health professionals too, psychologists, therapists, that, we're asked to hold a lot of emotion and using substances to cope with that is a very common mechanism for physicians.
Yeah. Yeah, we are one of the riskiest groups for suicide.
Just wanted to, to think about that idea of is the public perception changing, even if it hasn't changed enough. I think that this conversation, like you said, is far from over, and we're in a position to continue to foster that as people are paying more attention. We're having these conversations. We're encouraging them out in the world. So as we talk about with any problem behavior, what can you do as we're just introducing this block is to name the behavior with the people in your life. So that's just, thinking about that is normalizing that conversation and making sure that we're having ways to help here. I'm just going to let that dangle because I'll probably put that in like before I wrap up. But Nice.
But
Okay.
I think it's profound when we kind of expand our appreciation of what addiction can entail. As you mentioned, sort of this empathy that's necessary. I think there's a humility that is intrinsic in it as well, because it can affect anyone at any time in their life. I often think of folks sort of this spectrum of pre-addicted to addicted to a use disorder.
Mm-hmm.
When we talk about the tolerance and the dependence that's necessary, one of the other core aspects of a use disorder is that it begins to have negative consequences in our life. So like any use disorder in that big purple book that we often talk about, there needs to be issues with relationships, with occupational functioning. And if we kind of scour the entirety of our knowledge and understanding of addiction right now, and if you were to ask me what causes it, we can't really say, but we can say almost everything predisposes us to addiction, whether it's our genetic inheritance, whether it's our environment and adverse childhood experiences that someone might have in their history, or even the epigenetic, or kind of on top of our gene inheritance changes that occur to us throughout our lifespan. All of those things sort of leading to the conclusion that, we are all addicted or pre-addicted in various degrees.
Agreed. There's like different behaviors, different substances that might have cultural relevance specifically, but the idea of addiction, really, there's no socioeconomic status that makes a difference, no race, no religion that really shows certain things. So when Drew uses the term epigenetics, it's a big word, Dr. White. I'm going to hold up this book we've referenced a billion times. The Body Keeps the Score. The idea of epigenetics is the idea that trauma and our experiences do change our genetics. They do change pathways in our brain. They change genes that can then be passed down to our next generation. So that is that idea of epigenetics. So intergenerational trauma, not only from that psychological perspective, from that biologic perspective. So what Dr. White was hitting on there is a way that a lot of psychiatrists are taught to formulate a patient, which is biopsychosocial. So we'll dive into that in a little bit, but the idea that a person can be looked at from a biologic, genetic lens, psychologic, the things that have happened to them, and social life, who is involved in their life, what's that look like, education, and all those kinds of things. So in their social history. So Drew, let's dive into the stages of change and how we plan to use them this block.
Yeah. So when we look at this conundrum of addiction, right, it can affect us all. It at a personal level, this is literally changing your genetic makeup and some of your physiology. And I think one of the realities of how we as providers understand engaging treatment with individuals, as well as presenting a firsthand experience in what our approach to addiction treatment looks like. So the idea of a stage of change model is to present a way that behavior change can successfully be altered, embraced, and then maintained throughout the course of having an individual who is hoping to, whether it's stop their alcohol use, stop smoking, stop their opioid use. And it appreciates that does not happen in a binary nature. Usually folks pass through the first stage, which is this pre-contemplation stage that involves a lot of denial, right? There is no problem. If you came across this episode and you're like, why would two professional psychiatrists sit down and talk about something like addiction? That's not real. It's a moral failure, and you just gotta change your behavior. You could maybe potentially be seen as kind of being in this pre-contemplative stage around acknowledging addiction as an entity in our society and at the individual level.
Yeah, we've learned a lot about denial on this show, Drew, and understanding that is a psychotic level defense. You are not living in reality. So pre-contemplation implies that you are so defended against this problem that you are not seeing it how everyone else is seeing it. They're not seeing how it's impacting their life. And that's often some border between conscious and unconscious.
Yeah, I think it's really unconscious. I think folks, if we look at the different ways that addiction is often introduced to us, it's rooted in kind of social cultural values, sometimes often greater than our individual awareness. And so I think the antidote, if you will, I think that is really driven home as you look at the next few stages of kind of preparation and action and maintenance, which are all a continuum of how do I take that notion of I'm going to do something different to actually doing it and then sustaining that as a part of your life. There's a lot of different cliches that are thrown around like how long does it take to break a habit? But this is what we're talking about here at these
Yeah.
these points in the stages of change. Provide an alternative for your brain and your body and your day-to-day life.
Drew made a good point there where this model of change is not a straight line or even a straight one directional circle that this image here is making it out to be. It's much like a pendulum in that we can go backwards and forwards and swing both ways, similar to grief, where it's not really a straight line necessarily during the process.
Yeah, I love that lens. One of the things that goes hand in hand with this model of change is a number of different therapies. I know you touched on it, Dr. Solomon, about the motivational interviewing technique that really underpins the kind of the movement from some of these early stages into action and maintenance. And some other things that if folks are interested in this to dive into are kind of acceptance and commitment therapy, and some of these notions of how do we sustain, not only focusing on a potentially maladaptive behavior like an addiction, if you will, but kind of more pro-health behaviors, whether it's engaging in a healthier diet or an exercise program. I think the reason that we wanted to share the stages of change with our listeners today is it's very ubiquitous and can be a great lens to look at things. As we present addiction, again, I think that this is a wonderful and kind of natural model to also present the story of different individuals who are going through these stages. And the reason I mention that again is because as this model points out, a natural part of this cycle is return to use and relapse. We very infrequently work with individuals who, make this preparation to change and then they act on it and they maintain it and then they are sober for 80 years. There are some folks, like I've come across those individuals and they are kind of like my unicorns, right? Like I sit down and talk to them for hours, like, how have you done this? But often I think if we use those kinds of examples for people who are struggling with addiction, we set an unrealistic expectation, especially for the folks that are often supporting that person through a relapse or a, return to rehab or whatever it may be.
Drew was talking about action there and certain types of treatment. So in our action episode, we're going to bring back the good Dr. Mario Perez, who was in our dissociation and self-states episode. He works at a substance use rehab treatment center out here in Colorado. And so we're going to get a look into what inpatient means you sleep there, rehab looks like, try and debunk some myths and realities, and hopefully be able to talk to some patients as well who are in the midst of or who have completed rehab and talk about their experiences. So after you've acted and you started, working on things, Drew, when do you think the maintenance stage, that comes after action and maintenance, when does the maintenance stage start? Because I have a hard time understanding where action ends and where maintenance begins.
Yeah, to be honest, if I don't have an answer, I will call upon the forefathers and foremothers and forepersons who have done a bunch of research and will say, okay, once you've kind of acted and changed your behavior for so long, then you are in this next stage of your addiction journey. According to the most recent iteration of the DSM, we kind of look at that action to maintenance transition as sort of occurring hand in hand with a period of substance use disorder that we call remission, right? So that, like, hey, I've stopped drinking for a day, doc. Like, am I done? Am I
Not cured yet? Yeah.
The long and short of the hypothetical client kind of coming in and asking that question is that we've decided that at about 90 days, someone has reached a stage of early remission. And so if you've acted and you've maintained it for about 90 days, we're in early remission. Your brain is starting to heal. You are counteracting some of the biological changes that we see. And then I think maintenance sort of takes us into the 12-month period where we reach this sustained remission, which is when, per our most recent guidance and research, we have sort of, if you kind of put it within the disease model of something like cancer, you are about as in remission as you can be. Again, I think it's so much more complicated than that. And, we'll talk on the coming episodes, the reality of the experience of addiction. I don't think someone who just, kind of white knuckles it for 12 months and doesn't drink beer is no longer prone to some of the potential reasons that they may have sought substance use in the first place. But those are sort of the numbers we use, like 3 and 12 months.
On the show, the maintenance episode is going to include talking about therapies that work for substance use. So Drew mentioned acceptance and commitment therapy is a really positive one that we see a lot of. We're going to talk about Suboxone and methadone as harm reduction strategies. So we'll talk a lot about harm reduction, which is a big thing in substance use nationally in terms of programs that are trying to help, which is like, even if we're not curing everybody or they're never using a substance again, how can we make sure the amount of issues, the amount of functional impairment can come down? So harm reduction with medications like Suboxone and methadone for opiate use. We're going to talk about AA and Al-Anon as well, which are very popular programs for people struggling and family members struggling. So, and then relapse, we're also going to do an episode of relapse to normalize that process. And if you're a loved one of somebody who's struggling with relapse, how to help and how to seek support and how to go about that. So, Drew, I think we've done a nice job here kind of explaining and normalizing these processes. Guys, Dr. White is excited to show you the brain. The brain. We have not really thought that hard about the brain on this show. Drew, just for you to know, our listeners have really been thinking more about the mind and the heart and the soul, because we focused really on therapy. We focused on psychological concepts, psychiatric concepts, and less about like how your brain, works and how these problems come to be. So for the very first time in the Get In Fellas, We're Going to Therapy podcast history, I'm going to show you a picture of the brain. So it's a cartoon. So if you're squeamish, ain't no thing. I hope this doesn't bother anybody. But Drew, talk about just quickly, and then we'll dive in and take this picturing because it's a lot. But what are some of the names of the regions of the brain that are relevant during addiction?
I'm so excited to be the first person to poorly introduce neurobiology.
Because we're going to do psychedelics. We're going to do a lot of things that are going to be brain science heavy. Yeah.
So I'll give a general interest. As you said, Dr. Stone, this is the brain. If we break it down into parts, I kind of look at it sort of evolutionarily, right? Like our brains as creatures on this earth, as far as we know, have kind of developed three parts of their brains. There's the forebrain, which I think I see your little mouse circling there, is sort of the upper spinal cord and the cerebellum. And really, I had a physiology teacher once call it the lizard brain, right? There's not much different there between like us and your pets at home. If we look at what parts in the brain there are doing are really general homeostatic functions. So breathing, being awake, and having some movement. The reason we chose this picture of the brain, though, is because it is a little more complicated than that. So as you kind of move up in the brain and into this kind of gray area, and the dark gray, we see sort of this like midbrain, thalamus, amygdala, and I could name off all sorts of like fancy terms that you've maybe heard. But they're kind of the portions of the brain that start to control our emotional responses, our memory, and some of the things that make us a higher order organism. And then the outer cortex layer, the lightest gray there, is what we think make us human, right? But as I'm sure y'all have kind of implicitly done in kind of avoiding the neurobiology, is it gets a little messy as we as thinking creatures start to try to describe the things that make us think, and you kind of get in this whole circular logic. That being said, there are testable ways and objective measures that many neuroscientists have used throughout the years to try to understand these parts of us. This particular picture that we've chosen highlights some of the dopamine reward system and really the dopamine system in general, and it's all in blue. So in the blue areas here, we kind of see the highest density of neurons that are responsible for releasing dopamine. Their bodies sort of being in those little clusters there in the midbrain, and then they send projections out into our mood centers as well as our prefrontal cortex area, which will all be sorts of topics of conversation as we look at, ultimately one of the most important questions that addiction is rooted in, which is what makes us feel good.
We're going to get into some cool graphs here that Dr. White and I both exposed to in our training, which is how different behaviors or substances use that dopamine and give us that reward.
Yeah, so I look at dopamine as the OG stimulant, right? Like if we look at a lot of the substances, and even some of the conversation right now that is focused on, like, oh gosh, what happens to my dopamine when it is hypofunctioning? Like I'm not getting enough dopamine. Or when I think I work with folks and this topic comes up a lot, right? Like I'm depleting my dopamine. I don't feel good anymore. I think it's important to kind of start in the most general sense and see that this is a neurotransmitter, right? A chemical that our nervous system cells are secreting in response to a stimuli. And if we look at why dopamine is so important and kind of ubiquitously studied, is whether it's us or rats or something lower in the order there, that when we go and we are exposed to things that are very pro-life, so food and sex, we get a shock to our system with dopamine. That dopamine is released from that midbrain area where all that really dense blue was, and it passes into the rest of our brain, particularly hitting things that are responsible for movement, for awareness, for attention, for memory, to remind us, for example, I think one of the biggest metaphors that I think describes life on Earth sometimes is summed up by some great rock artists that mention that we're all just kind of rats in a cage. And was that button that I just pressed a good one or a bad one? Did I get shocked or did I get satisfaction? And as humans, we have a lot more stimuli to calculate and a lot of things to internalize, but ultimately that surge of dopamine that we see that has taken over our cultural conversation is not too complicated. I think what complicates it is the fact that our system is in a constant homeostasis that modulates what happens as we get more and more and more dopamine exposure. As you can imagine, that's overwhelming. And so what happens if we're scrolling through our phone and getting a quick hit of dopamine and looking at a greasy hamburger that looks delicious or a insert whatever excites you, our body actually starts to downregulate the number of receptors in our prefrontal cortex and sort of in our ventral tegmental area, these portions of our brain that respond to that. Because we couldn't just sit there and stimulate our dopamine receptors over and over and over again all day. It would be overwhelming.
So it's really a lack of connection to more stable, less high hitting behaviors in humanity, you're saying? So like people are on their phones more. We have these, things that turn over faster. And so people are just getting used to getting these dopamine hits. I really think of social media. I think of technology. I think of TikToks, that things are moving so fast that people's dopamine systems are shutting down because they're just so sensitive to those spikes that again, I have a lot of men and women too, but men who come to clinic with this dopamine depletion concept, feeling depressive symptoms, apathy, which makes sense. If you're not getting rewards from the normal things in your life because your brain's gotten so many rewards, then you're going to feel crap.
Yeah, precisely. I think when we break down addiction from a neurophysiological standpoint and our understanding of it, it has really three components. One is this binging and sort of excitatory.
Hold on, Drew, I'm going to stop you. We have not shown.
Yeah, so the binging aspect of addiction, I think, is best exemplified by a couple of slides that I threw your way, Dr. Solomon, that really show, relatively speaking, how dramatic the response to our dopamine system is at baseline, right? If we look at some of the baseline rewards that we're used to, and this is shown here. Thanks for pulling that up. So these two examples here are kind of looking at normalized levels of dopamine in our nucleus accumbens. So if you're ever want to sound smart at a cocktail party and talking about where dopamine responses lead to satisfaction, it's sort of in your nucleus accumbens. And these levels,
I'm always looking for stuff like that, Drew. That's stuff to hit at parties,
it really, it's kind of a self-fulfilling prophecy. Not only will you seem smart, you'll have a dopamine release as you build an intimate connection with whoever you're sharing this to. It's kind of, as we mentioned, what dopamine levels are about. If you take here, these are some mouse models, but when exposed to food, you can see this just dramatic little spike, right? Going from 100 to 150. I can't really read that. I think that's like micrograms, or you'll have to trust us. Generic units, yeah. But about a 50% increase and a notable response in your brain chemistry. And as we kind of talked about, this is not unique just to food. If we look at a sexual stimulus, so kind of this pro-life, procreation drive that we wouldn't be here without it. I know food and sex are really universal things. We see almost 100% increase in the dopamine levels. Dopamine response, we seek it out and we continue to thrive, and generations go on seeking out the things that have allowed us to continue living here.
Correct.
And
yes. The plan that's made humans and really animals is that, right, the stuff that allows us to live. And evolve, makes us human, is due to these things. So of course it makes sense that you want these things to feel good.
So I think the notion of people kind of nowadays wondering, what's going on with my dopamine system, is important because a lot of things stimulate this even more than our drive for food and sex. So here on the sort of illicit drug side of the conversation, we have amphetamines. Yeah, I love the whistle there. You almost have to stop for a second and just pause. Something that if we go from kind of baseline to over 1,000, which is like a tenfold increase in baseline in our dopamine levels, is going to dramatically reinforce our drive to seek that out. And what is that, Dr. Solomon? A little methamphetamine there?
That's amphetamine. Yep. It's and guys, this will make sense too, because we're seeing on this slide 3 of the 4 of these are stimulants. So nicotine, we know, functions as a stimulant. We talked about how people with ADHD tend to have higher rates of smoking because they serve as, like amphetamine is Adderall, nicotine serves as a stimulant that helps people regulate. So nicotine bumps you over 200, then you move up the ladder to cocaine, which hits over 300. And so then, right, we started this big boy. That's why methamphetamine really does have the ramifications it has. It is super, super strong. People get violent. People get aggressive. They're awake for days on end using methamphetamines because it's really intense.
Yeah. No, and I think it goes hand in hand with your point earlier, kind of this hypothetical person coming in and saying, I feel down. I feel this dysphoria. I just don't feel like I'm feeling as good anymore. I don't think you can have a conversation like that without a previous experience, an exposure to some stimulus, some life situation in which you spiked, right? Like, it's not like, hey, I'm just not feeling great anymore. It's I'm not feeling great compared to where I was. And that speaks to the second tenet of kind of the neurobiological changes in addiction. On one hand, we have the binging, the intoxicating drive. We also have this withdrawal phenomenon. Touched on it a little bit, right? This notion of overstimulating our system, leading to a downregulation in our receptors for dopamine. We also see that the firing of our dopamine receptors is decreased. And so it's kind of sort of these two heads of the same coin that are going on. And clinically speaking, it leads to a couple of things. So we not only have this part of addiction where we're trying to feel good in a way that we can't really feel good anymore because our system doesn't allow it, but we also are trying to not feel so crappy, right? We're trying to not feel bad. We've got this dysphoria, this anhedonia, all related to a system that has sort of been hindered by excessive use. I think anyone who has been really involved in excessive or continued exercise might be able to relate to the notion that you can go to the gym one day and really work out. And if you go 2 days in a row and 3 days in a row and 4 days in a row, you actually hit diminishing returns. A part of gains, if you will, come from recovery.
Yeah. Yeah, the muscle has to have time to heal and fill in the gaps that exercise causes. So, yeah, the literal physical gains. Unrelated, move yourself a little, center yourself a little bit more. Yeah, there we go. You've been chilling over there for a minute. And so, right. So, Drew, and this is tough. We're out here in Colorado where everybody exercises a lot. And I think it's really, not really thought about in our culture that exercise can be pathologic. It can be addictive, just like any other thing, any other behavior. When I have people in my clinic say, like, I need to exercise every day, that is a pause for me because, yes, physical movement is good for us every day. But also, if you have that psychological connection that I don't feel good, I don't feel happy, I don't feel myself if I don't exercise every day, that's going to be tough for any behavior.
Yeah, and I think it speaks to one of the reasons I have felt inspired to include addiction into my psychiatry practice, which is that at the core, when we look at trying to help folks who are on their recovery journey, right, you are giving them back control.
Yeah.
And, we could talk about addiction in a lot of different ways. We did just kind of give a brief kind of neurophysiological overview, but it's not very common that you could talk to someone who's going to say, hey, I'm an addict or I'm struggling from addiction or I used to, where they won't admit that rooted in that is a loss of control. That is one of the DSM checkboxes. So It's one of the 9 that we look at, but I think it's an important one from the patient's perspective. As we kind of distill down all of these neurochemical changes, you're trying to seek a way to feel better. You're trying to reduce a pain that's there. But I did pull one quote. I know we could go on for hours and hours about addiction, and that's why you called me here. But
Yeah.
I have a quote that I want to share for folks, because I think the person who said it is a great resource if folks are interested in understanding addiction and its complexity. But the quote is from this family med doc named Gabor Mate. I don't know if you ever talked about him on your show.
Yeah, he's a big deal. I was looking for like figures who don't necessarily lean any way politically, but have been good role models.
Yeah.
He was a name that came up a lot as I searched for those.
Yeah, and I think one of the reasons he's come across my radar is he writes a lot about his work in Canada and in different areas with patients who struggle from addiction. And he put it this way. He said, addictions always originate in pain, whether felt openly or hidden in the unconscious. Far more than a quest for pleasure, chronic substance use is the addict's attempt to escape distress. And I can't disagree at all with that notion. I want to mention it because we're kind of presenting this balance of like, I'm going to try to feel better or maybe not feel as bad. But if we look at chronic substance use, it does evolve to just trying to not feel so bad.
Yeah.
And culturally, I know you and the speakers to come are going to kind of grapple with some of the ways that addiction is presented in our world. But if there's a lesson I want to share with anyone listening as we kind of look at this shift from pre-contemplating, like, is addiction is it a thing to care about, to listen to maybe a handful more of episodes about, and contemplating and understanding about it. I think for me, one of the biggest lessons I've had is that addiction's real pain is spent in the day after day journey of fighting withdrawal. Right? It's not like folks are out there I'm getting high and feeling great. It is a struggle to not slip into the depths of hell, as I've had some people describe, like opioid withdrawal.
Yeah, absolutely. And if you're interested in Dr. Mate, he wrote In the Realm of Hungry Ghosts is probably his most popular work, a really popular book from 2008 that describes some of the science, but also a lot of the psychology and just the feelings like Drew's been talking about. There's just this idea, guys, that's really what we're aiming for this block, Dr. White. So thanks for really hitting on that, is that addiction is one of those words, or alcohol use disorder, being an alcoholic, being a drug addict, right? That has so much emotional fuel behind it. But to normalize the idea is what we're really trying to do here, Drew. And I think you did a nice job helping us do that. So just to remind everybody what our episodes are going to look like going forward. So we use that stages of change model. So today we did pre-contemplation, which is like, what is addiction? Why does it matter?
To this idea is really knowledge, right? So if you're kind of listening to this and you're saying, oh, actually, I do know someone who's addicted, or maybe I spend too much time or energy doing certain things in my life, that sort of signifies this pre-contemplation to contemplative or contemplation stage, where you start to build up an awareness that I do see a problem. I see something that potentially is impacting me in positive ways. It helps me handle my emotions, helps me get through the day, but also it's impairing some of the things that I value in life. And so as we kind of go from denial to awareness, you have this beautiful growth that in an ideal world kind of leads to this new behavior, right? This preparation around, okay, this is something that is real and tangible, and I want to change it. And so maybe I will change some aspects. And so folks can look at preparation as that kind of that catalyst of, I might go to AA, maybe I should, call my friend instead of get high tonight. It doesn't necessarily signify that you're making those changes yet, but you are at the cusp. And if you stick there, better, you're making progress. Many folks that we work with in our general outpatient psychiatry world are often kind of preparing to make changes in their life. It's sort of this like behavioral activation point where we're constantly looking for the reinforcement that we get from different behaviors versus kind of this devil, and some of the things that are wrapped up in these more negative behaviors.
Yeah, Drew, in the contemplation episode, I'm having my buddy Michael Damioli on, another Ohio boy who has his own substance use treatment center out here. He's a social worker and an addiction therapist and has his own treatment center out here. So he's excited. We're going to talk about, for the people listening, that with contemplation, we're going to talk about motivational interviewing, which is the way that we try to help people who are maybe just starting to think about giving up a substance, how to help engage them in a way that encourages change talk. So that's really good. And you're going to be able to take some of that stuff and use it with people in your life who you're trying to draw out some willingness to change. And we're going to help also people that are listening identify warning signs, how to know when there's a problem. We're going to touch on the idea of interventions and do more of that in the preparation episode. So just wanted to give some ideas as we think about what these stages are, how we're going to use them, and what the listeners are going to learn each episode this block.
Yeah, I think it's so important. We can look at this process as sort of a static evolution from one stage to the next, but it is constantly flowing. And
what do we know about it? And including some brain science to help people understand this is not just a moral failure of an individual person. There is a lot of chemistry and biology at work here that leave people predisposed to addiction. In the contemplation episode, again, we're going to talk about how to help encourage change talk in people in your life. So how to help people start thinking about getting treatment. And those are skills that anybody, non-clinicians, can learn too. Contemplation will also include knowing warning signs when there's a problem, defining those use disorders in a little more detail, like we talked about with the Purple Book. Preparation is going to be when treatment kicks you in the face. So court system, family structures, interventions, when you get tossed into change, almost whether you like it or not. Action is the next stage. So again, we're going to have Mario on to talk about rehab and different stages of care. So rehab, partial hospitalization to the outpatient world, and what does treatment look like as we look to move forward. That maintenance stage, again, is going to be the outpatient world. You're doing okay. Like why AA emphasizes the chips. Everyone's probably seen that. You get a 30-day chip, 90-day chip, right? And those people that are struggling really hold value in a physical object around, their days of sobriety. And then again, we're going to do a relapse episode too. So 6 weeks we're taking on this. We're going to try and include as much useful information, make it fun, accessible, when really there's not much fun about it. Okay. So today, maybe compared to last episode where me, Mike, and Richie got to talk about what is mental health, a lot of positives, how our growth has shown what therapy can do. Addiction's a downer, guys. It's a huge problem in our country. It's becoming an increasingly important problem with social media and technology. And again, as COVID isolated people, addiction became a big, big thing. So just knowing that, we're going to try and make this fun, but mostly just make it accessible and actionable for people, whether you're struggling with addiction yourself or have a loved one who's doing so. Drew, thank you so much for coming, man. We may see you again this block as I look to fill it out, but certainly we owe Drew a lot of thanks. He really helped sit down with me and Christine one day and carve out what this block should look like, and going through it with the stages of change was Dr. White's idea. So thank you so much, Drew.
Thanks for having me.
All right, guys, we're going to try to theme our Bro Motions Hall of Fame members during this block. So we'll be back with somebody who did good work or exemplified positive traits based on addiction. All right. See y'all soon. All right, so this week's Throw Motions Hall of Fame inductee is former NHL hockey player Paul Bis-Nasty Bissonnette. Born on March 11, 1985 in Welland, Ontario. His mother, Yolanda, was an office administrator. His father, Cam, was a steel worker of French-Canadian origin, so a bilingual bro. And just because it doesn't mean anything about today's segment, but Paul's actually half black, which is only an actually surprise term because that's pretty rare in hockey. Probably a little more normal up in Canada, just as an American who isn't really quite sure. His professional career is really not eligible here, really not important here. And we're going to dive right into what happened this week that has had us want to honor Paul as a Bro Motions Hall of Fame inductee. So a little more background. Paul had a pretty unremarkable professional career. That's not to say anything other than, he played with Sidney Crosby on the Penguins at one point. He ended his career on the Phoenix Coyotes. What has made him famous is alongside former NHL hockey player Ryan Whitney, they co-host the extremely popular hockey podcast on Barstool Sports called Spittin' Chiclet. You're not a big sport fan, that's right. That implies you get hit in the face and you spit out your tooth. That's the chiclet, all right? We know hockey players are famous for those beautiful smiles. And so it's a really good show, super popular, super funny. And Paul, as a result, got the call up to doing NHL on TNT where he is an analyst along with Wayne Gretzky. So clearly Paul's been popular. People really like him a lot. Why did we want to talk about Paul Bissonnette this week? Is because he made headlines. And he made headlines for something that I wondered, is that a good thing to make headlines for? We're going to share a clip here from the Spit and Chicklets podcast, and we can all decide. We're going to think about this together. Is what Paul did good or bad? Paul will tell the story himself.
I guess I'll just start from the beginning. So I go to this place called Houston's, one of the best ran chains known to man. Very military-like. The staff is incredible. Last night after that outline call, I go over there around like 8:30. I've gotten to know the staff pretty well, and because it was so busy, actually, the manager who I talk to sometimes, they were both in there. So they're all running court, trying to organize everything, get everybody what they need. And so I'm putting in an order for a salad, and all of a sudden you could just hear a commotion at the bar area, and the girl that was taking my order, like her jaw kind of dropped, and I look over and there's this gentleman in a red golf shirt along with about 9 other guys. He's being asked to leave by the smaller assistant manager. And this guy is just screaming in his face, creating a ruckus. The whole restaurant now is looking over there like, what is happening? Luckily, that guy ended up walking out of the restaurant after screaming in the assistant manager's face. And then he starts making his way back over to where the other 9 guys were, where the main manager was trying to calm these guys down and explain, hey, listen, like if you don't have a seat in this area, you can't drink. That's just kind of the rule. Like, so this gentleman with a lime green golf shirt, who's kind of being the antagonist, I guess I'll just start from the beginning. So I go to this place called Houston's, one of the best ran chains known to man. Very military-like. The staff is incredible. Last night after that outline call, I go over there around like 8:30. I've gotten to know the staff pretty well, and because it was so busy, actually, the manager who I talk to sometimes, they were both in there. So they're all running court, trying to organize everything, get everybody what they need. And so I'm putting in an order for a salad, and all of a sudden you could just hear a commotion at the bar area, and the girl that was taking my order, like her jaw kind of dropped, and I look over and there's this gentleman in a red golf shirt along with about 9 other guys. He's being asked to leave by the smaller assistant manager. And this guy is just screaming in his face, creating a ruckus. The whole restaurant now is looking over there like, what is happening? Luckily, that guy ended up walking out of the restaurant after screaming in the assistant manager's face. And then he starts making his way back over to where the other 9 guys were, where the main manager was trying to calm these guys down and explain, hey, listen, like if you don't have a seat in this area, you can't drink. That's just kind of the rule. Like, so this gentleman with a lime green golf shirt, who's kind of being the antagonist, starts putting his finger in the manager's face and backing him up onto the back side of the bar. I'm kind of starting to look around, and like nobody's really getting up and doing anything, and they want to get a drink. They want it now. They ain't leaving without a fight. After about watching this for probably about 15 seconds of him getting in his face, and now the manager trying to remove this guy's arm from his face, I get up and I go over. And I walk over, I grab the guy's arm. I said, listen, buddy, if you keep harassing and assaulting the staff here, I said, we're going to go outside and we're going to have some problems. The minute that left my mouth, the guy beside him starts throwing punches. And then next thing you know, there was about 4 guys swinging at me. So we're in the middle of the bar area, and I am just throwing, and I'm eating punches. I'm getting pushed against the bar. My shirt gets ripped off. As I'm kind of getting pushed out towards where the main door is, we're still swinging. There's like a statue towards the right side as you go to the bathroom. And luckily I was able to kind of duck underneath that and make my way out the door. Well, we're all of a sudden now in the parking lot, and they keep coming. And we end up in kind of where the first rock area is, where there's gravel. And they get me down. They're throwing punches. I'm able to get back up. I lose my shoe. I'm taking some and I'm giving some. And I would say about the entire time, there was about 5 to 7 of them. As I continue to back up and maybe involved with one of them, I now see the gentleman who originally struck me. He's a bald guy. He's now assaulting the assistant manager again. He throws him up against a car, and I'm saying, what are you doing? I'm like, these people are good people. Like, what the fuck are you doing? They were seeing red, and there was no stopping them, and I just kept fighting away. Now, we kind of rounded the corner where the CVS is, and that bald gentleman who originally threw the first punch now starts making a beeline and sprints past all the guys coming at me, and I catch him with a nice right and buckle him. I was very, 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 very happy about that. That seemed to ignite them again. I make my way around the dumpster at the CVS, and 4 of them got me. They got me on the ground, and I ate 3 kicks, 1 in the neck, 2 in the head, was able to get up. And now at this point, I have no shoes on. I got my pants, no shirt. I finally am able to run in the CVS, and then they didn't come in the CVS. And thankfully, the cops were called right away while the thing was going on in Houston's. And by the time the altercation was done, they were able to book 5 of these guys, and they got them either, whether it was in county jail or the local jail. I think the whole ordeal probably lasted about 3.5 minutes, like give or take, 30 seconds. I just want to thank all the police officers, the ambulance and firemen who came over and helped me out, checked the vitals, and got me kind of back to normal to at least get home to sleep late in the night. Like, I'm so fired up right now. I would be willing to waive every single charge if I could go behind a fucking barn somewhere and go in 1v1, every fucking guy, one after the other.
It's a wild story, and I'll just finish. Thank God you're all right, dude.
All right, we have the mic off. So some reflections off that video. 1, Biz, handsome dude. Check out the nose, broken in a bunch of places. If you're watching the video, that's not how he usually looks. So this dude is broken and will need surgery as a result of his effort to step in when he saw wrong being done. Quick aside, Houston's great chain, as Biz shouted out, one of my mom's favorite restaurants. Shout out Vicky and our many trips to Houston. So Biz was in a situation at the bar. He goes out to eat by himself. He's famous. That's what he wants to do. And he sees a group of guys giving a hard time to the management and just being violent. He's a big dude. He's an experienced fighter as a hockey player. He steps over and says, hey guys, you going to cut this out or are we going to have a problem? And he gets jumped from there. And so we can ask ourselves on this show, like, what was Biz doing anything wrong? Were there better ways to go about that? And that's what I like about this show and the stance we're taking. Like, yeah, I think if we're trying to think about this the best way, could this have been solved without violence? And also, violence is an unfortunate part of the world, and it is unfortunately a part of the way that people communicate. And to think that that's all of a sudden magically going to go away does not fit with the harm reduction concept that we had earlier, which is we need to be realistic and honest about this problem. So if I'm in Biz's shoes, and what I've asked everybody to do here is KGBs on this show, which is if you see somebody doing wrong, we should call that out. We should not just be innocent bystanders. And sometimes how that goes might not go great, right? So Biz goes over there, says we're going to have a problem. He gets in a fight. He helps break up this fight. These guys end up beating up some of the managers. They all end up going to prison, to jail. And Biz says in a very, very, healthy masculine, but masculine way, let me get each of these guys one-on-one and fuck them up, and I won't press any charges, which hopefully has a shot. I bet that'd do good money. Barstool would love to make money off that idea. So line him up, Biz. So I was thinking about that because this happened earlier in the week, and I was at my brother. Shout out David and Janie. Their son Tobin had his first birthday party this week. He's adorable, great guy, great kid. You guys are doing a great job, David and Janie. And my buddy David's friend Jordan has an 8-year-old son, Max, and he was reading a book called The Warrior Kid. So I won't go too deep into what The Warrior Kid is, but it's a children's book where this kid has an uncle who was a Navy SEAL, I believe, or a Marine, and he teaches him the ways of the warrior kid. So there's guys and girls that are both warrior kids. It's not really a gender-based construct, but I looked at the beginning of the book and thought, what is this warrior kid philosophy, and is this healthy for my brother's godson to be learning? So you can see warrior kids wake up early, they study to learn, ask questions if they don't understand, train hard, exercise, eat right. And as you go through here, what caught my eye thinking about the situation with Biz is the warrior kid trains to know how to fight so he can stand up to bullies to protect the weak. I teach people how to parent for a living. I'm a child psychiatrist. Do I like that this book is condoning violence? Or do I like that this book is setting a realistic example for what goes on out in the world? Okay, so training to fight versus training to defend honor. I think in a lot of people's worlds, especially for my buddy David's buddy Jordan, who was ex-military himself, this is going to be a part of the world and part of what they're teaching their kids. And so this stance of, hey, we need to be prepared to stand up for what's right, stand up for people, stand up for those who can't defend themselves is something as KGBs we should be internalizing. Does it need to be physical? No. These are kids. Physical? Yes. Do adults get physical? We just saw it with Biz. Yes. Now, I'm not going to be teaching martial arts on this show or telling you to go do a jujitsu class, though a lot of my friends like it. But this idea of if we're going to be intervening and we're going to be standing up for ourselves and others, we do need to be prepared for whatever's going to happen there. So posing that question of like, is violence the answer? Well, no, it's not the only answer, and it's usually not the right answer. And there are plenty of people who don't understand reason, who don't understand man and treating people fair and kindly. And if you're in a situation where, you know, you got to make sure that they understand that and things like that are going to happen, well, you know, some people need to get punched in the face. I don't mean that all the time. It's not something I'm proud to say. And I think it's also a realistic stance for this world. And as we look to stand up to rights, there's some people who going to need that. I'm sure Biz is happy he did it. And he took these dudes who were really just causing a problem at the bar for no reason and made sure they understood that's not good. At a minimum, they're all going to have hefty fines to pay and a night in jail. So, guys, we're going to wrap up the show as we do with sources and takeaways. And remember, as we induct people to the Promotions Hall of Fame, it's not always going to be a Bob Ross. You know, it's not always going to be a Mr. Rogers. Sometimes it's more complicated than that. We can still be good male roles.
All right, team, let's close out as we do, citing our sources and listing our takeaways. For the introduction, I want to thank the Theo Vaughn podcast, a bunch of good dudes down there. I know I'm a fan of his and Shane Gillis as well. Also to thank harmreduction.org. That is a national organization that works at the federal level, again, to increase awareness around harm reduction programs and the movement at large. Thinking about the interview today with Drew, he used some of his resources to thank Dr. White and the University of Colorado, both psychiatry residency and psychiatry addiction fellowship, for helping give me and Drew both a lot of good balance and background on those things. Thank Paul Bis-Nasty's own podcast, Spit and Chicklets. That's a Barstool podcast. We borrowed some of that, and the Warrior Kids series for helping us think about this contrast in terms of parenting. And you can find them on the internet, warriorkid.com. There's a few books, and they have a podcast and also a social media account too. So I know some parents who've used those books and really feel like it's a helpful, balanced way of thinking about parenting, especially parenting young boys. Certainly not the worst way to be going about it, let me tell you, as far as all the resources I've seen. So what are our three takeaways? One, that addiction impacts us all. It knows no bounds, race, religion, socioeconomic status. Two, we can understand addiction. Take away a feeling we don't want, give ourselves a feeling we do want. It's simple. We've all done it. To say you have not means we need to open our eyes. Three, as our boy Paul Bissonnette taught us, that, look, KGBs, we don't greenlight violence in many situations, certainly not violence against women or violence in situations that don't call for it. But we also want, as men, in our definition of masculinity here, to be able to stand up for people who can't stand up for themselves, or make sure we're standing up for what's good and moral. And sometimes that gets ugly, as Paul Biz taught us. On that note, let's try not to get into any fights this week, but noting that we have a role to be kinder and gentler in this world and calling out bullshit from people when we see it. All right, we'll carry on with addiction next week with my good buddy Mike Damioli, talking about contemplation as our next stage of change with addiction. All right, y'all have a good week. See you next time.